Welcome to this episode of Buddhi Insight. At the Indian Federation of Neuro-Rehabilitation's annual congress held in Mumbai, India last week, I had the opportunity to debate Professor Michael Clarke from Canada, a world leader in neurological music therapy. He took the position that unlike NMT or neurological music therapy, other forms of music therapy and indeed other non-drug and non-device therapies like mirror therapy and yoga were less well researched and therefore less well established. This podcast recounts my counter to Professor Clarke's considered position in that debate. Let me begin with a simple question. When a patient recovers after a neurological illness, if it's stroke or traumatic brain injury or Parkinson's disease, what is it that truly drives that recovery? Is it the therapy? Is it the brain? Or is it the interaction between the two? Because neurorehabilitation is not a linear science. It's a complex, adaptive, network-driven process, one that depends on timing, context, motivation, meaning, and the biological state of the individual at the moment of intervention. In modern neurorehabilitation, we have made remarkable advances. Neurological music therapy, through the pioneering work of Professor Michael Clarke at the University of Toronto, has brought scientific rigor, structured protocols, and replicable evidence into music-based interventions for movement disorders. Mirror therapy, through the elegant visual feedback mechanisms, has demonstrated that cortical reorganization can occur without actual movement, simply by manipulating what the brain sees. And indeed, it's a great honor for us in India that Professor V.S. Ramachandran, working out of UCSF, was the person who pioneered this idea of mirror therapy based on his extensive work on phantom limbs. These, NMT and mirror therapy, are powerful, well-validated tools. They show us that the brain can be guided through carefully designed external inputs in order to reorganize itself. But they also reveal something important. Each approach captures only part of the picture. First, let me begin by acknowledging neurological music therapy because it deserves that respect. It's protocol-driven, measurable, and reproducible, and techniques such as rhythmic auditory stimulation, which uses external rhythmic cues to entrain gait patterns in the brain, patterned sensory enhancement, and therapeutic instrumental music performance are each grounded deeply in neuroscience. They engage auditory motor coupling through the reticulospinal and corticospinal tracts, the basal ganglia timing circuits that are disrupted in Parkinson's disease, and the cerebellar coordination networks essential for motor learning and supplementary motor area planning that underlie voluntary movement initiation. Neurological music therapy structures time, and in doing so, it restores movement. One very interesting experiment that Professor Clarke shows in his talks is that of a patient with Parkinson's disease who freezes repeatedly every time he comes to a place like a doorway. And what he shows is that when there is just a sound in the background, a rhythmic sound in the background, for example, a clap, that sound, without any instruction to the patient, is good enough to make the person walk through that door without freezing. And that is one of the principles of NMT. But what about music beyond protocols? Improvised music, cultural music, devotional music, the music that carries personal memory and emotional significance for the individual patient. Do we say it has no therapeutic value because it has not been reduced to a protocol? Or do we say that we have not yet developed the methodological tools to measure its value, and that the absence of measurement is a failure of our instruments and not the failure of the intervention itself? Because when a patient listens to music that moves them, music that's tied to their identity, their culture, their personal history, we are not just engaging motor circuits, we are engaging the limbic system, which processes emotion and emotional memory. Remember, in many of my podcasts I talk about this, draw a line between your ears, and there on either side of your brain is the limbic system. We are also engaging the default mode network, which I talk about very often in my talks, which supports self-referential thought and identity. And the prefrontal cortex, which assigns meaning and enables appraisal. We don't stop here. We also engage the autonomic nervous system, which modulates arousal, heart rate, and physiological state. Neurological music therapy measures movement. Music, on the other hand, more broadly engages the totality of human experience. And that is not a weakness. It is the very thing that we have yet to learn how to study properly. And I started by talking to Professor Thought in this vein, that the absence of evidence is not the evidence of absence. And indeed, when something has persisted across centuries, across cultures, across healing traditions, it demands not dismissal, but better questions. And this is true not just of music therapy in all its different forms, it's true of Ayurveda, it's true of yoga, it's true of Tai Chi, it's true of a number of traditional disciplines that have contributed to human well-being. Now let's turn to mirror therapy. Often presented as simple, but in reality very profound, it's just a box and a simple mirror which is placed in the midline of the box. I've actually done this with Professor V.S. Ramachandran way back in 2004 in the Voluntary Health Services Hospital, and we just brought out a cardboard box, we got hold of a mirror, we placed it in the middle, we had this patient with phantom pain, and we created that visual illusion that we were looking at, the patient was looking at the unaffected limb. And the reflected image of that unaffected limb appears in the position of the affected one. So if you think of your right and your left hand both going into the box, and your left hand is paralyzed and your right is not, you're looking at the right hand, and which is normal, and your brain is tricked into believing that the left hand is normal. This is not just a trick. It's a demonstration of the brain's deep dependence on visual proprioceptive integration. And this illusion drives visual motor coupling, cortical remapping in our sensory motor cortex, resolution of sensory motor mismatch, and this is a key mechanism in phantom limb pain and learned non-use, and also in the interhemispheric rebalancing between damaged and intact hemispheres. Let me explain that. You've had a stroke on one side, which is causing you hemiparesis and problems on the other side, which has become weak. And what we are trying to do is to rebalance the affected side with the normal hemisphere of your brain. But more importantly, mirror therapy restores something deeper than movement. It restores the brain's belief about the body, the internal body schema that tells the brain where the limb is, what it can do, and whether it belongs to the self. And let me explain that a little bit to you. When a person has a certain type of paralysis, there is sometimes denial that the limb is mine. So I've seen patients who will be lying on the bed, The affected limb, which is paralyzed, is right next to them. And if you say, "Where's your right hand?" they'll say, "Here." But whose hand is that? "Oh, that's not my hand, that's somebody else's hand." And that kind of denial is because the brain is rejecting the affected limb as its own. Movement is not therefore just execution, it's representation. And the motor cortex in our brain does not simply fire commands, it operates on an internal model of the body. And when that model is disrupted by stroke, nerve injury, or amputation, function collapses, not because the muscles are gone, but because the representation of the brain of the body in the brain has been lost. And here I'd like to draw your attention to something that you'll see in a number of neurological books, and you can look this up online. It's called the homunculus. The homunculus is the representation of the entire human body in the brain. And it's a wonderful picture when you look at it, so much so that your body is thrown out like this with your feet hanging in the middle of your brain. It's very striking, and I would urge you to look up the homunculus. Now, mirror therapy, therefore, works at this representational level, and that's what makes it profound. But at this point, we must step back, because what we are seeing is not just a collection of therapies. It's a collection of entry points into the brain. Let me repeat that for you. It's not a collection of therapies that we are seeing. It's a collection of entry points into the brain. And recovery, therefore, is not about restoring a single function, a hand grip, a gait cycle, or a swallowing reflex. It's about restoring the integrated network that supports cognition, which is the wonderful ability to think and remember and calculate and feel, all those things that we have, emotion, motivation, and our own experience of the self. The brain operates through dynamic tension. There is a frontal regulation, and there is then limbic reactivity. There is the default mode network and task-positive systems. There is excitation, there is inhibition. And recovery is not just restoration of what was, it is a rebalancing of what remains, and that is a fundamentally different clinical problem. Now, if we are looking for a single intervention that engages the brain across multiple systems simultaneously, the thing that stands out is India's greatest export to the world, yoga. Yoga is not just posture, it is breath, pranayama, which directly modulates the autonomic nervous system through vagal afferents. It is attention, dharana, the voluntary anchoring of awareness. It is interoception, the internal sensing of the body's physiological state through the insular cortex and its activation. And it is stillness, the capacity to remain present without reactivity. Through these mechanisms, yoga engages the vagus nerve. And please remember that the vagus nerve is one of 12 cranial nerves. It is the only one cranial nerve that leaves the brain and supplies the entire body. And the only other neural pathway that leaves the brain and supplies the body is the spinal cord, which we all know very well. It has a bidirectional brain-body signaling mechanism, and it is intimately networked with the autonomic nervous system, both sympathetic and parasympathetic branches. It also connects the insular cortex in our brains, the anterior cingulate cortex in our brain, and the limbic system. The clinical consequences of yoga are therefore very measurable. Yoga reduces sympathetic overdrive, the chronic fight or flight state that is ubiquitous in neurological illness and that impedes neuroplasticity. It enhances parasympathetic tone, promoting the rest and digest state in which learning and recovery are optimized. and it improves emotional regulation, the capacity to experience emotion without being overwhelmed by it. And therefore, I want to place before you that yoga is not just some form of exercise. It is a form of neural modulation. And this neural modulation is achieved by working through your vagus nerve, by activating the vagus nerve, which connects your brain with your body, and it connects very critical parts of your brain with your body. Now, in a rehabilitation context, this matters enormously. A patient in chronic sympathetic overdrive cannot learn. A patient who is emotionally dysregulated cannot participate. Yoga addresses the state of the system before we ask it to perform. And in a sense, yoga regulates state. And then we come to something called mindfulness, perhaps the most researched bridge between ancient contemplative tradition, like those in Buddhism, and modern neuroscience. Mindfulness does something extraordinary. It does not stimulate the brain. It does not add input. It changes how the brain relates to itself, how it processes its own activity, how it responds to its own narratives, how it manages the constant stream of self-referential thought. Mindfulness engages the default mode network, the brain's narrative and self-referential system. The salience network, which determines what is relevant, the frontal control systems, which enable top-down regulation, and the limbic system, which generates emotional responses. And it produces outcomes that are directly relevant to neurorehabilitation. Reduced rumination, the repetitive, self-focused, negative thought loops that are a hallmark of depression and chronic illness, reduced emotional reactivity, the ability to experience difficulty without catastrophizing, improved sustained attention, the cognitive infrastructure on which all rehabilitation depends, and greater psychological flexibility, the capacity to adapt, to accept, and to re-engage with a changed life. Now, these are not soft outcomes. They are the foundation on which functional recovery is built, from being the story to observing the story. The default mode network deserves special attention in neurorehabilitation. It is where we experience identity, the continuity of who we are across time. It supports narrative, the story we tell ourselves about our lives, and it processes meaning, the sense that our experience matters. In neurological illness, the default mode network is often disrupted, sometimes by direct structural damage, sometimes by overwhelming cognitive demands of coping with disability, sometimes by depression and withdrawal. Patients do not just lose function, they lose a sense of who they are. They report feeling like a different person. Their narrative breaks. And this is precisely where mindfulness becomes critical in rehabilitation, because it does not restore movement, it restores the relationship to self. And without that, no amount of motor training will feel like recovery to the patient. And connecting all of this from the brainstem to the gut, from the heart to the prefrontal cortex, is the vagus nerve, the wandering nerve, our 10th cranial nerve, a bi-directional superhighway between brain and body. 80% of the vagus nerve fibers are afferent, which means they carry information from the body to the brain. The network layer addresses the software, clinical psychology for cognitive restructuring, behavioral therapy for habit formation and maladaptive pattern modification, and neurofeedback for real-time brain state training. The system regulation layer addresses the operating environment, Ayurveda for constitutional assessment and lifestyle alignment, yoga for autonomic and state regulation, lifestyle medicine and naturopathy for sleep, nutrition, and circadian rhythm optimization. In our integrative programs, the results are consistent and clinically meaningful. Cognitive outcomes improve, particularly in sustained attention, executive function, which is planning and organizing yourself, and processing speed. Behavioral symptoms reduce, including agitation, apathy, impulsivity, and maladaptive coping patterns. Emotional regulation stabilizes. Patients demonstrate reduced reactivity, improved mood, and greater resilience. And importantly, patients report improvement in their lived experience, in the quality of their relationships, in their sense of purpose, in their capacity to re engage with life. This is not theoretical. It's clinical reality and lived clinical reality for us. And it tells us that rehabilitation outcomes must be measured not only in function but in experience. And therefore, this is not alternative medicine but expanded medicine. The brain can be engaged through 5 fundamental pathways, each corresponding to a different dimension of human experience. Time, through rhythm engaging the motor system via music therapy. Space, through vision engaging body representation via mirror therapy. State, through physiology engaging autonomic regulation via yoga. Self as a narrative, through meaning engaging the default mode network and via emotionally significant music. And the self as awareness through observation, engaging metacognition via mindfulness. And these are not, therefore, competing therapies. They are not alternatives to one another. They are different gateways into the same brain. The question, therefore, is not which one is best, but which combination, in which sequence, for which patient, at which stage of recovery. Those are the questions that we really should be asking. And my argument to Professor Thought was, it's not that we need to operationalize everything in the way that he has wonderfully operationalized neurological music therapy and then measure it in a way that modern science is willing to accept. That's great for publications. We have a huge history and heritage of experience with these different traditions. And this experience is global. This is not just in Indic traditions. And the importance of something that has survived for centuries and continues to be attractive and useful to people cannot be just set aside because it's not willing to align itself into a measurable format that modern science is demanding. And I think this was a centerpiece of the argument that I was making. Now let me tell you a Buddhi Clinic story to illustrate how we work with people. Mr. S, a 52-year-old businessman, consulted us, burdened as he was by a complex web of physical and psychological challenges. Following a COVID infection 2 years ago, he had begun experiencing persistent cognitive lapses, fluctuating moods ranging from irritability to agitation, muscular stiffness, low back pain, and a host of gastrointestinal issues, including bloating and acid reflux. Compounding these were problems like fatigue, palpitations, dizziness, sleep disturbances, and an increased sensitivity to noise and light. Symptoms that, taken together, seriously eroded his capacity to function both at work and at home. When he came to us, we carried out a comprehensive multidisciplinary evaluation, and this is done by our team of physician, psychologist, physical therapist, electrophysiologist, and we use this to uncover several key findings in every person. Through his tests, although EEG and ECG and other precision tests were normal, the tests for autonomic dysfunction detected what is called postural orthostatic tachycardia syndrome, or POTS. POTS is diagnosed through a significant increase in heart rate on changing posture. Usually, 30 beats or more when one progresses from lying to standing, accompanied as well in some cases by a drop in blood pressure, a systolic blood pressure drop of more than 20 millimeters of mercury and a diastolic drop of more than 10 millimeters of mercury when you go from lying to standing up. Mr. S also suffered from marked anxiety, moderate depressive symptoms, and mild cognitive impairment, and had a score of 17 out of 30 in our comprehensive autonomic symptom checklist, highlighting the extent of his dysautonomia. In light of these findings, the care team decided on an integrated treatment strategy merging established modern medical practices with ancient healing wisdom to holistically address both his physical and his psychological ailments. Central to his modern medical management was the judicious use of pharmacotherapy to stabilize autonomic imbalances, manage his mood-related symptoms, and alleviate discomfort. And here I must point out that it's very important to be willing to consider judicious drug treatments. People read about horror stories on drug treatments on the internet and then start refusing all drug treatments. That is not the right approach. There are drugs that can be extremely helpful and they can be used without causing harm, without causing habituation to patients. And I'd like everyone to keep this in mind. Now, we've talked about the autonomic nervous system and how it starts in our limbic brain. And the use of drugs that stabilize brain activity is therefore both logical and necessary. Augmenting this approach in Mr. S's case was a cutting-edge novel intervention, transcutaneous auricular vagus nerve stimulation. While vagus nerve stimulation has been long studied for its role in modulating the balance between the body's sympathetic and parasympathetic systems, the fight or flight and rest and digest systems, in TVNS, a small electrode stimulates the auricular branch of the vagus nerve near the ear. These sessions, administered 4 times per week for 20 minutes each, are designed to prompt a parasympathetic response, helping to calm hyperactive stress circuits in the body. Research increasingly indicates that TAVNS can reduce heart rate variability issues, lower inflammation, and alleviate mental health symptoms, making it particularly relevant for managing complex dysautonomia of the kind that Mr. S had. It has other uses too, TAVNS. We use it in epilepsy to control seizures. We use it in depression to improve the mood. We use it in migraine to stop the headaches, and it's also helpful in cluster headache. Neuromodulation of this kind paces the nervous system in a manner similar to the cardiac pacemaker, except that this is non-invasive and therefore done repetitively on consecutive days. In Mr. S's case, he had psychological care, which included several hours of cognitive behavior therapy to mitigate severe anxiety and moderate depression, and cognitive retraining exercises to help his neurocognitive symptoms. It is well known that neurocognitive dysfunction that is perceived but not detected in formal testing, also called subjective cognitive dysfunction, is an important outcome of depression and anxiety. At Buddhi Clinic, we practice medicine at the intersection where modern neuroscience meets contemplative tradition, where clinical precision meets human experience, and where the biology of the brain meets the lived reality of the person. Buddhi Insight is our ongoing effort to share that intersection with the wider world, with clinicians, caregivers, patients, and curious minds. Each edition takes a single question from our clinical practice and explores it in depth, not as settled doctrine, but as an open inquiry into how we understand illness, recovery, and the self. Incorporating pranayama, breathing exercises, shukshma vyamaya, gentle stretches, chanting, and yoga nidra, deep relaxation, the program empowered Mr. S to calm his overactive sympathetic drive and strengthen parasympathetic tone. In tandem with a balanced, gut-friendly dietary approach, his digestive issues were addressed by reducing acid reflux triggers, incorporating probiotics to support healthy gut flora, and adopting smaller, more frequent meals to alleviate bloating. Indeed, in Buddhi Clinic, we have just launched a range of nutraceuticals, including one called Gut Intelligence. And this program helps people build better gut endurance, better gut balance, and get rid of symptoms like irritable bowels, acid reflux, and constipation. After 5 weeks, Mr. S reported remarkably reduced dizziness, numbness, and muscular pain. He had substantial improvement in his mood and sleep and greater overall resilience. With his postural autonomic syndrome significantly mitigated, the POTS, he returned to a more productive and satisfying daily routine bolstered by sensible nutrition, regular exercise, and continued yoga practice. And indeed, what this journey of Mr. S tells us that it is possible through this form of integrative medicine, which blends modern science like vagus nerve stimulation with the wisdom of ancient traditions, Ayurveda and yoga, blended with physiotherapy, psychological therapy, and naturopathy, to come back to health. One can actually journey back to good health and well-being. And I'm very happy to report that Mr. S has gone back to being a successful businessman without all the challenges that he was facing both in his professional and his personal life, thanks to COVID-19 and long COVID symptoms. All this brings us back to the question of evidence. Why does neurological music therapy have stronger evidence while broader-based music-based interventions do not? Not because one works and the other does not, but because our gold standard, the randomized controlled trial, was designed for a specific kind of intervention. Single molecules, single variables, linear dose-response relationships. I'd like to remind everyone that the RCT was developed for drug trials. We continue to try and use that model to assess non-drug treatments. And when we think beyond drugs and when we think beyond devices, interventions of this nature, which are part of integrative medicine, Ayurveda, yoga, acupuncture, acupressure, reflexology, and a host of other such interventions, including regular forms of music therapy or mirror therapy, are very difficult to set into the context of a randomized controlled trial in order to test. So the failure, therefore, is not of the intervention itself, but of the way in which we are intending to test it. These interventions are multi-component, context-dependent, experience-driven, and deeply individual. They are complex adaptive interventions that are operating on a complex adaptive system, the human body and the human nervous system. And what we are trying to do is study such a complex adaptive system with tools that are designed for linear interventions. And when the tool cannot measure the phenomenon, the problem is with the tool, not with the phenomenon. So what do we need? And this was part of my debate with Professor Thought. We need naturalistic outcome studies embedded in real clinical practice. Mixed methods research that captures both quantitative change and qualitative experience. N of 1 trials and single case experimental designs that honor individual variability. And outcome measures that go beyond impairment and measure function, behavior, quality of life, caregiver burden, and crucially, the patient's own experience of self.